Good evening. Today the presentation will be on congenital malformations of lower urinary tract. If you recollect, we had earlier done sessions on malformations of the upper urinary tract, where we essentially discussed the malformations that occur in the kidney and also the upper ureter, like PUJ obstruction, etc., etc. Now I'm coming down to the lower urinary tract. And here, essentially, we'll be discussing malformations associated with bladder, the penile urethra, the posturethral valves, etc. It will not be a complete discussion today because the number of malformations are many. And for example, these are the various conditions which will come in the list of the congenital malformations. Somewhat extensive for one lecture. So therefore, I decided to look at the whole subject and then pick up those issues which are very important for you clinically for exam, let us say. For example, if a case of hypospadias is available in the ward or in the OPD, it will definitely be picked up as a case for your examination. And posterior urethral valves perhaps will come through either X-rays or in some form of discussion, it might come. UV reflux, as a matter of fact, I've already discussed earlier. Today, I'm not included. In other words, these sections, the lower part of the discussion, we will not do today because there won't be time for more than these two. And I will complete these. These are relatively shorter sections for us who are general surgeons. And I will complete this thing in another talk. So let us start with hypospadias first, because this is very common actually. And so therefore, this actually is an anatomical congenital malformation. In other words, not so much functional, but there is a distortion in the anatomy itself. And this obviously occurs during the development of penile urethra, right? So, and what it is, I'll show you the pictures in the pathophysiology as to where exactly the problem arises. It is at the level of the urethral fold. And as a result of that, there's an abnormal positioning of the urethra. In other words, instead of urethra being here, as it normally is, it could position itself here, here, any of those. There are several spots, which again, I'll show you in a picture later on. So this is one of this. There's an abdominal position of the urethra. And there is also a penile curvature, the issues. That means it's called chordee. Basically, for example, if the urethral opening is out here, then this segment, this area, will undergo fibrosis. And it also contains a structure called urethral plate, will undergo fibrosis. And this will tend to pull the penis down. And that is called chordee. So that becomes a very important phenomena that needs correction for various reasons. So therefore, to summarize the slide, it's abnormal. It is a congenital malformation of the male external genitalia. There is also a malformation of the prepuce. Normally, the prepuce will go forward like this and tend to turn back. So there are two layers, right? And in case of the upper part, the prepuce is normal. But in the lower part, the development stops at the level of wherever the urethral orifice is. So similarly, corpus spongiosum also stops developing at this area. So these are the defects which go with the hypospadias. In fact, why is it called hypospadias? Hypospadias means hypo means under, and spadias means reference to the urethral orifice. So this is under the penile shaft, and therefore it's called hypospadias. Let's look at why it develops. Now, normally the development in this area takes place in two phases. There is one phase which is the primordial time, that is the 5th to 8th week of gestation. And subsequently, there is a hormonal phase. That is, at that time, the genitalia are differentiating and testes produces androgens at that point of time. And that androgens affect the development of penile urethra at that stage. Let's go to the diagram, then maybe it will be easier to make out. Now, this is the non-hormonal phase, the primordial stage. What have we got there? We've got a genital tubercle in front, and we've got the urethral folds out here, and the clavicle membrane sitting in between, right? And then that finally, in case of females, it would become labioscrotal swellings. And in case of males, obviously, it will go into the formation of the scrotum. And then you have the urethral folds and you have the urogenital membrane. This is in the 7th week. And as the development takes place, a stage comes when you have the urethral folds sitting on either side. You can see them here sitting on either side, and there is a small gap in between. This area tubularizes in case of males and then forms the penile urethra. In females, the development takes the course of labia majora, etc. So this, therefore, is the non-hormonal phase, and this is common for both males and females. Hypospadiasis obviously does not occur in females. Now, what happens in the next stage? In the next stage, the urethral fold starts closing from below, as we are showing here. These two edges come together and slowly a groove is there. And on that groove, that tends to canalize into the formation of the urethral canal, right? So now that is what is being shown out here in various steps. And then in case of hypospadias, as the closure moves from proximal to distal, at some point the development stops, as we are seeing here. See, this is the area where the development has stopped. The glandular urethra develops from an epithelial tag and it takes a different line of development. It is coming inside and finally it meets the normal urethra. But in case of hypospadias, the development stops at some point. Various areas it can stop. At some point it stops. And that is the hormonal phase. And this is on the effect of androgens. So in other words, the malformations can take place either in the non-hormonal phase or in the hormonal phase. The next slide, I'll show you what are the effects of that. Now, supposing the development stops there, what happens? It depends on exactly where the development has stopped. Here is a situation, closure is starting from here and going up, right? So here is a situation where it's stuck at the perineal level itself. So then it forms perineal, then you have scrotal, then penoscrotal. This refers actually to the posterior hypospadias. Is also called third degree in some classifications. And as you move up, you can have a proximal penile, which is at the penoscrotal junction. Then you have a midshaft. Then you have distal penile. Then corona glandis. This is the area of corona glandis. So that becomes subcoronal. Then becomes coronal and glandular, right? So at any point, the urethral development can stop. And then the urethral orifice remains there. So now what happens to the area distal to it? And the area proximal to it, the urethra remains essentially normal. There may be a stenosis of the urethral orifice, but it remains essentially normal. The problem is with this segment. This segment, where the urethra is supposed to form, this is the segment where there is something called urethral plate, right? We'll talk about it in the surgical side. Now, but basically, this undergoes fibrosis, and that bends the penis, and that results in caudy. In other words, the penis can become like this. That results in caudy. So when a case presents to you, what are the problems you will have? You will have one, foreskin issues because the foreskin has only gone till here. And two, you will have the caudy issues. And three, you will have the problem of urethral orifice. So these are the three which will have to be subsequently handled surgically to produce a normal looking penis and as far as possible a normally placed urethra. Now, it's a common condition, like I said. What is the etiology? How common? I'll show it to you in epidemiology. What is the etiology? So etiology is supposed to be both genetic, this is one, endocrine, and environmental factors. The genetic factors, it is polygenic, more often in males. I said, like I told you, that females don't have this problem. So more often in the male, it's a polygenic thing. What is the